Okay, moving on. Mental health and social care. Martin Knapp, the K is silent. By chance, another health economist I know reasonably well. He's based at London School of Economics, which is about 1 kilometre south of London School of Hygiene, Tropical Medicine, where I'm based. He argues that social capital may be particularly important with respect to mental health and social care. Because if we take mental health, it's true that most mental health illnesses are chronic conditions. Obviously some are not, but most are. Whatever we do know about them, they are a complex combination of many factors: biological, environmental, social causes. We certainly also know that significant stigma and discrimination with respect to patients suffering mental health difficulties. And so he would argue that mental health, in particular, the role played by, potentially played by social capital, might be a really important one. Rather more important than perhaps some other patient groups that don't have these quite such a complex etiology, don't have so much stigma and discrimination. And with respect to social care, he emphasises that in virtually all countries, informal carers, unpaid carers, play a major or the major role in providing social care. And he would argue that a lot of these individuals are helped continue in their role as unpaid carers if there's more social capital. If there's less social capital, they themselves then find it difficult to continue in the role of unpaid carers. And so he would argue that while health policy generally maybe should be interested in social capital, people making decisions in the context of mental health and social care should particularly be sensitive to the potential role of social capital. Now, the last bit I want to sort of touch on is this. It's the potential contribution of social capital to the value of healthcare, and that social capital may bring a lot of benefits in terms of our valuation of healthcare. Now, we have a tendency, health economists have a tendency to focus on health technologies, and to what extent do health technologies help us improve or maintain health? Not just drugs, but a huge amount of the effort goes into evaluating new drug therapies and what is their potential contribution to improving health. And we do that, I think, partly because things are relatively measurable when we're talking about new drugs. If we're talking about new drugs, in order to get permission from regulators, there's typically randomized trial data. And a randomized controlled trial gives you a very good prospect, not a guarantee, but a very good prospect of measuring treatment effect, identifying what is the impact of this drug compared to some other therapy on the patient's health. It's back to being measurable. It's highly measurable, and I think that's partly why it attracts so much interest. Of course, the other reason, perhaps a more obvious one, is there's a huge industry out there coming up with new drugs, and it's a massive industry. And naturally enough, health economists are quite attracted towards the opportunities that brings. Now, there are many, as I'll be talking on Wednesday, I'll be talking about this issue of using economic evaluation to assess the cost effectiveness of new drugs. And as will become clear, I hope, on Wednesday, it's not easy. It's still really very difficult. You've got much better opportunities with respect to data, evidence, and so on, but it's still very difficult. But what's clear is it's much more feasible to assess the potential contribution to health of a new drug than it is with most health policies. Most health policies are difficult to evaluate. They're difficult to evaluate partly because trialling the policy is not usually an option. It's pretty rare where we can randomize different people or different locations to a different health policy. There was a very famous experiment done called the RAND health insurance experiment done in the United States back in the 1970s, where they did randomize quite a large number of individuals to different insurance plans. And because it was done as an experiment, the belief was you were going to get a better estimate of the impact of different insurance policies or schemes. But that's pretty unusual. We don't usually have that opportunity. And I think social capital is a bit like that. It's really quite difficult, for example, to imagine some sort of randomization process. Now, you sometimes may get what's sometimes called a natural experiment, where almost as an unintended consequence, you've got one group or one location exposed to a particular policy and another not. What we sometimes find is when we're introducing a policy, it's quite difficult to introduce it everywhere at once. And so there's always some locations which may be leading ahead of others. There's always some that are further behind. Now that does give some opportunity. It's got its own problems as well, but it does give some opportunity to identify, if you like, the treatment effect of the health policy. What is quite interesting about health technology assessment, and particularly evaluation of new drugs, is you almost forget about the health service. All you're focused on is, if we introduce this new drug, what will the effect be on patients' health? What will the effect be on the change in resource use? We barely stop to consider what else we need for the drug to work. And what else we need is a well-functioning health service. Now, in countries like England, and in countries like Japan, and in countries like parts of the population in the US, they have well-functioning health service. And so you don't have to worry about are there enough doctors and nurses in order to implement the change of treatment strategy. But in lots of other countries, that's not the case. You've got a missing input. You're not just combining doctors, nurses, radiologists, pharmacists, drugs, beds together, but you've actually got a whole infrastructure that you're assuming is present for things to work. Another way of saying this might be, we're assuming there's adequate social capital. And so, if there is, the health policy may well work quite well. If there's not, it may work much less well. And that bit is missing whenever we are evaluating new drugs. Or at least, if we're doing it in a country like the United States or Japan or England, it's missing. What is that contribution of social capital to producing the health benefits?